Hello and welcome. I'm Marcia Mott, the Health Promotions Coordinator for UF Health. Today is World Osteoporosis Day. About 54 million Americans have osteoporosis. Studies suggest that approximately 1 in 2 women and up to 1 in 4 men aged 50 or older will break a bone due to osteoporosis. We have 2 great speakers for you today. Our first speaker is Joy Wright. Joy is a pharmacist who joined UF Health in 2005. She performs clinical services for the UF Health Care One Clinic, which is a transitional clinic for patients who are discharged from the emergency department and or the hospital. She also develops pharmacy policies, performs compliance audits, and serves as a consultation pharmacist who is responsible for 9 off-site locations. She serves as a mentor and preceptor for students at the University of Florida College of Pharmacy, and she also works with pre-transplant patients and other services such as palliative care. Joy is passionate about sharing her knowledge and expertise about managing osteoporosis with others. Our next speaker is Dr. Evans Heithaus. He's a vascular and interventional radiologist with UF Health. Dr. Heithaus graduated from the University of Mississippi and attended medical school at the University of South Florida. He completed his diagnostic radiology training at Baylor University Medical Center. He received a subspecialty fellowship in training at UF Health in vascular and interventional radiology in 2018. And shortly after that, he joined UF Health as a faculty member. Dr. Heithaus has received numerous research awards, including the Roentgen Award Research Award for the Radiology Society of North America. He has also published several textbooks chapters, as well as multiple articles in peer-reviewed journals, including the New England Journal of Medicine and the Journal of Vascular and Interventional Radiology. Dr. Heithaus also served for 8 years in the United States Army. He looks forward to finding minimally invasive alternatives to help and care for his patients. If you have any questions for our speakers today, please feel free to submit them using the Q&A button at the bottom of your screen. We have a large audience today, and I know there's going to be a lot of great questions out there. Keep in mind, we can't provide medical advice. I'm going to do my best to get to all the questions that we have. If you have specific questions about medical treatments or medications, you should contact your physician or a pharmacist to get more information. Today's webinar is recorded, and a link will be posted on ufhealth.org/wellness. And I'm also going to send one in a follow-up email. Thank you so much for attending today. Joy, I'm going to go ahead and turn it over to you now. Thank you.
Thank you so much, Marcia. I am so excited to be here to give you a brief overview of osteoporosis and its treatment. I will tell you that I am Canadian by birth, and if you hear me say some words a little bit differently, it could just be my accent, and I hope you can all understand me. Prevention of osteoporosis is very important to me, as my dad was diagnosed with osteoporosis. My goal is to provide information to everyone on ways to prevent it, since once you have the diagnosis, you have already lost a significant portion of your bones. So what is osteoporosis? It comes from the Latin and Greek origins, meaning porous bones. And we can see it on DEXA scans imaging to be a lowered bone mass and a reduced bone strength. As Marcia was saying, there's about 54 million Americans who are at risk of breaking a bone each year here in the United States. And it's responsible for 2 million fractures that happen. Often people do not know they have osteoporosis until a fracture occurs, leading this to be called a silent disease, since there are very few warning signs. The warning signs can include things like loss of height, change in posture like stooping or bending as pictured in the image on the screen, or it can even be shortness of breath due to a decreased lung capacity from the spinal fractures caused in the vertebral, or pain from those fractures that can show up in either the upper or lower back. Some of the most common fracture sites tend to be the hip, the spine or vertebra, and the wrist. And these fractures can occur during activities of daily living, not some sort of traumatic thing that happens. Reducing fall risk in the home and increasing balance through exercise are great ways to prevent breaks from a fall. And osteoporosis is noted to cost the US healthcare system about $19 billion per year, and that number has increased every year. So this is a picture of what osteoporosis looks like under a microscope. On the left, you'll see the normal bone that has lots of connecting tissue holding it together, and it has like a sponge-like appearance. On the right, after many years of losing that connectivity, it is hard, even with medications, to build any of that support structure back, which is why many of our treatments are aimed more to prevent further loss than to actually build bone. This is also why it's important to start talking to teens and young adults about making sure they implement this lifestyle choices we are going to talk about to make sure they keep as much of that bone as possible. Many of the studies we are seeing with nutritional supplements are given much too late in the course of disease, or they're given for too short of a time period to see a difference. And then you'll see headlines in the news that they are not beneficial. It's not cost efficient to actually study minerals for 40 to 60 years. So once somebody gets osteoporosis and they have a fracture, the complications from those fractures can lead to these things happening further down the road. And so once someone has had a fracture, it's much harder to return to the same life that someone has had before the fracture. It puts you at much higher risk of having another fracture as well. One study indicated that after hip fracture, only 50% of patients got back to the same level of independence they had before the fracture, and over 30% of them required a move into an assisted living facility because of the hip fracture. Vertebral fractures of the spine can be very painful. And after fractures, often patients may need assistive devices like canes, walkers, or wheelchairs due to instability. If a move is necessary into somewhere like an assisted living facility, they may lose their family home, or they may lose their independence, which can impact mental health and also cause a loss of the ability to care for other people who they may have been taken care of before the fracture. So is there anything to be concerned about? I think all three of us have talked about the statistics that 1 in every 2 women over the age of 50 will have an osteoporosis related fracture in their lifetime. And that's compared to men at 1 in 4. So yes, it is more common in women than men, but that's still not a small number of male patients affected with osteoporosis. And according to the National Osteoporosis Foundation Osteoporosis Fast Facts sheet, this includes more women than heart attacks, stroke, and breast cancer combined. So that's a huge impact on our older women population. Also, mortality or death because of a fracture is up as high as 20% in the first year after a hip fracture. And some studies and case reports are indicating that men may have a higher risk of mortality even than women from a hip fracture. So who should we be testing for osteoporosis? This original information came from the National Osteoporosis Foundation guidelines, although there are many different guidelines and different groups interested in osteoporosis. The U.S. Preventative Services Task Force and their recommendations do not include recommendations on testing in men, which is why I've put it in brackets, because they felt it had a lack of available evidence. However, the National Osteoporosis Foundation does support testing in men. And so all women 65 and older or all men 70 and older should be tested with a bone mineral density test. Postmenopausal women and men who are 50 and older should also be tested based on these criteria: having a fracture history, having a weight less than 127 pounds, or having a first-degree relative like a mother or a sister or brother with a fracture after the age of 40 that was not traumatic. And so everyone should talk to their physician if they feel they have these risk factors present. Some other additional reasons to test in those guidelines are things like personally having a low trauma fracture after the age of 40, a loss of height, ongoing glucocorticoid treatment, which is medications like prednisone for even as short as 3 months over the course of the lifetime, and smoking. And so if you are smoking, please consider quitting, as this will benefit your bones. Looking at some of the other guidelines, like the American Association of Clinical Endocrinology, the North American Menopause Society, and the American College of Physicians, we've pulled in some other risk factors that may be a reason to be tested for osteoporosis. Some of the major risk factors from those other guidelines are things like malabsorption syndrome, where you have a condition that you're not absorbing your nutritional things like minerals or other vitamins. These can be things like celiac disease, Crohn's disease, ulcerative colitis, and others. And the other ones are often related to hormones, things like primary hyperparathyroidism, hypogonadism, which is low sex hormones, and early menopause. This can be natural early menopause before the age of 45, or surgical menopause having a hysterectomy. Also on that list, as we mentioned earlier, is the propensity to fall. And so again, looking at those fall risks in the home and trying to minimize them is considered a way to reduce your risk for a fracture. Other minor risks are things like autoimmune conditions such as rheumatoid arthritis, which could be because of the inflammation in your body or because of their treatment using corticosteroids. A past medical history of hyperthyroidism, and certain medications like anticonvulsants. We use seizure medications for all sorts of things, from migraine treatment and prevention and neuropathic pain to treating epilepsy. So it's not just for epilepsy. Could also be chronic heparin therapy, and we even know warfarin, which is another blood thinner, can impact your bones. And then some nutritional and lifestyle things like calcium, drinking too much with excessive alcohol intake, excessive caffeine intake, and having a weight loss of greater than 10% from age 25 also seem to be minor risk factors for getting osteoporosis later in life. So what is the test like? It is much like an X-ray. It's called a dual energy X-ray absorptiometry, or DEXA scan. And it should be painless, and it measures the density of bone, typically at the hip and the spine and or the wrist. The scanner will take the data and put it into pictures and graphs, and the bone is seen in white while the fat and the muscle look like shadows. Recommendations are that you should be tested using the same machine each time you go, because different machines are calibrated slightly different. But if it's truly not possible to use the same machine, then results from different machines may be able to show trends. If you're found not to have osteopenia or osteoporosis on your first DEXA scan, you likely only need to be scanned every 5 to 10 years because it takes a long time to have bone loss. However, if you are found to have osteopenia or osteoporosis, you will likely need to have scans more often, up to every 1 to 2 years, to see if the treatment you're receiving is the best for you, or whether we need to change what medication or other treatments you're receiving for osteoporosis. So when we get the test back, you will there'll be lots of information, but the most common things that we're looking for are your T-score and your Z-score. The T-score is compared to a young healthy person, and it's of standard deviation units, and we'll see whether your bone density is above or below the average. And so if you are a +1 to a -1, that would be considered normal, that you have the right amount of bone that you need. However, if it's -1 to -2.5, that is considered osteopenia, and anything less than -2.5 is considered osteoporosis. And then your Z-score will tell us whether it's related to aging or not. And if it's not related to aging, then we need to look for secondary causes, like some of those lifestyle things and the medications I mentioned earlier that may be contributing to your bone, and we may need to change those things. Bone density over time does decline at a usual rate. The National Osteoporosis Foundation says about 85 to 90% of peak bone mass is reached by about age 18 to 20. However, it still can be affected minimally until about the age of 30 to 35. Once someone reaches about 30 to 35, depending on whether they're a man or a woman, they will start to have a slow loss of bone. In women, this is due to a decreasing amount of progesterone circulating in their body. For men, it's decreasing amounts of testosterone. Women have a rapid loss for approximately 2 years after they reach menopause. The average age for menopause in the United States currently is 51. So this usually happens in the early 50s for most women. For men, they do not have a rapid loss period. It's just that slow, gradual loss until about age 75 or 80. And then as you can see from the picture, it seems to even out unless there is something else going on based on those lifestyle risks or medication risks that we would need to treat for later than 80. As I mentioned, lifestyle modifications are very beneficial at any age. And so let your children and or your grandchildren know how to lead a healthy life to achieve their best bones. The first on the list is to reduce caffeine. Generally, most will recommend 2 cups or less a day of coffee, tea, or cola. Colas also may contain phosphoric acid, and this is a second reason that can be harmful to bones and why sodas are not generally seen as healthy. I have already mentioned to quit smoking. And for alcohol guidelines, none of the osteoporosis guidelines that I have found have had a specific recommendation for alcohol. So for this, I typically go with the cardiovascular guidelines, which say that women should limit it to 1 beverage per day, which would be a small glass of wine, a regular sized beer, or 1 shot of hard liquor, and men should have no more than 2 of those in a 24-hour period. I'm going to be discussing calcium and vitamin in the next couple of slides. Another thing that's really good is to focus on weight-bearing exercise. So some movements are better than others for building your bones. Swimming, cycling, and walking typically are less beneficial for bones, but are awesome for an overall heart healthy program. So if those are your primarily activities of choice, make sure to pair those with weightlifting, stretching, or functional exercises to make sure your bones are getting a good workout. Yoga and Tai Chi are great options for helping with balance and have less impact. If you want to use walking as your source of exercise, consider a high-intensity interval training approach by increasing and decreasing your pace and having a varied route that includes some inclines and hills at different places in your walk, and change the route every time you go walking. If you can tolerate running and jogging, these are even more beneficial and jumping on your bones, but take into account your situation and if those exercises would be safe for you. Adding weights to walking, like ankle and wrist weights, or a weighted vest in your chest area, can be useful for preventing osteoporosis, but those who are diagnosed with osteoporosis should avoid these types of movements or these types of weighted activities because they can put more, they can increase your risk of fracture. And as I mentioned earlier, you should assess the home for fall risks, making sure things like cords are tucked away, avoiding throw rugs, and minimizing piles on the floor that can be a trip hazard, and keeping your hallways and walkways as wide as possible. And also, if you have stairs in the home, making sure that those stairs have adequate lighting so that they are visible and not a fall hazard. Because there's so many different therapies, I'm going to go through this part very quickly, but you should discuss with your physician the best therapy for you. The first 5 types of medications are considered to prevent further bone loss. So they're not actually bone building medications, but help prevent the risk of fracture going forward by keeping the bone you have. And so these are things like bisphosphonates, the hormones, selective estrogen receptor modifiers, calcitonin, and rank L inhibitors. Each year, you need to be reevaluated on your need for the medication. Some can only be used short term, while others can be used for a longer term. If you're at very high risk for a fracture or have had a fracture in the past, some people will recommend a drug holiday after 5 to 10 years. But for some patients who are at extremely high risk, that may just mean switching drug classes and not actually stopping medication altogether. And no matter what therapy your doctor chooses with you, you still want to incorporate all of those good lifestyle habits that we talked about on the previous slide. So parathyroid hormone analogs and sclerostin inhibitors, those last 2 drugs on the list, are the only ones known to build bone, but they both are limited to very short periods of time. Parathyroid analogs should never be used for more than 2 years of therapy, and a sclerostin inhibitor should only be used for 1 year of therapy. From a 2019 efficacy meta-analysis, these indicated that the least efficacious on this list typically are abandronate, the selective estrogen receptor modifiers, and calcitonin. However, there may be other reasons why you want to use these medications because they can have other benefits in other areas. So most patients are typically going to start with a bisphosphonate as the first line therapy for osteoporosis, as these drugs are the least costly. They are oral, so it's a tablet that you can take sometimes daily, sometimes weekly, sometimes even monthly, and they seem to have the best efficacy. But if while on these therapies you have a fracture, you may need to go to some of the more costly therapies at the bottom, like the rank L inhibitor, the parathyroid analogs, and the sclerostin inhibitors, which all cost in the thousands of dollars per dose range. So as I mentioned, I would speak about calcium. Calcium is the most studied nutrient that can play a large role in bone health. Recommendations are 1,000 milligrams per day of elemental calcium for adults, increasing to 1,200 milligrams per day as we age. However, those patients who are at risk of kidney stones should be careful not to exceed those limits, as anything closer to the 2,500 milligram a day mark will make their issue worse. Some sources of dietary calcium. This chart is taken from the National Institutes of Health website that is online by the US government. So typically 1 serving of dairy will have approximately 300 milligrams of elemental calcium. So this includes 1 cup of milk, 1.5 ounces of cheese, or about 6 ounces of yogurt. Many people who are lactose or dairy intolerant will tell me that they get their calcium from green leafy vegetables. But as you can see from the bottom part of this chart, things like turnip greens, kale, and broccoli, you have to eat very extreme amounts of these items to get enough calcium to meet that 1,000 to 1,200 milligrams per day. Soy and nut milks, as well as orange juice, do not naturally contain a lot of calcium. However, some of these products have changed how they are processed or will be fortified, which means they will add calcium in them before it's finished manufacturing and shipped to you. So please read the labels and see if the milks, the alternative milks that you may be drinking or your orange juice may have calcium in it. A lot of times they're going to add calcium carbonate as the calcium, and that tends to settle out. So if you do have that in your, especially the fortified orange juices, to make sure you shake the bottle every time before you drink it, or you're going to get all your calcium at the last cup out of the bottle. So if you're wondering how much calcium you get in a day, read your food labels or use an app like MyFitnessPal or Spark People to get an idea of how much calcium you get each day and take an average of what you would eat in a normal week. Then you will know how much you need to supplement. So it's your diet amount of calcium plus your supplement should equal that 1,000 milligram or 1,200 milligram goal. On food label packaging, 100% of the recommended daily intake, or RDI, is considered to be 1,000 milligrams. So if it says it contains 30% of your daily calcium limit, it's going to have approximately 300 milligrams of calcium in it. For vitamin D, the recommended daily intake for adults has recently been increased to 600 units or 15 micrograms. And if you're over than 70, it's been increased to 20 micrograms or 800 units. Typically, vitamin D does not come a lot from what we eat, but is more made from us being exposed to UVB rays from the sun exposure in skin. And this is prevented with any sort of sunscreen that's an SPF greater than 8, or if you're sitting behind glass. And so, yes, we want you to use sunscreen to prevent skin cancer. And so you may need to get your vitamin D from other sources. And so I like to follow blood levels of vitamin D to make sure that you're getting the right amount for you. And the typical lab values in the United States tend to be 30 to 80 nanomoles per milliliter of 25 hydroxy vitamin D. If you've looked at your recent UF labs, they have changed it to say anything less than 20 is deficient, 20 to 30 is inadequate. So again, on that low side, and they've actually increased the levels to 30 to 120 is the normal range. Most people that I have asked them to get their labs done have told me that they've had between 20 and 35 nanomoles per milliliter, which is on the low side. Again, vitamin D is such a vital vitamin that we need it not only for our bones, but it also can help prevent cancer because it's an antioxidant. And it is also used to prevent lung infections and respiratory infections. And so because it's such a healthy vitamin for us to have, I like people to supplement until their labs reach at least the middle of the range at 50. And I think that's probably a really good way to go. And that is what is recommended by the National Institute of Health. In the time of COVID, I would even be okay coming upwards towards that 80 limit at the top. I do not recommend going all the way to the 120 as some other providers do. And so just at the bottom there has been a labeling change. If you're used to seeing it in international units, the FDA made that mandatory change last year, and it's now in micrograms per dosing. So from our food, our best sources are fatty fishes, as you can see at the top there between cod and trout, salmon and tuna fish. However, you can get a little bit from some fortified milks. I was pleasantly surprised to see mushrooms on the list as having at least a small amount of vitamin D in them, liver and eggs. Again, some milks are fortified, but again, to get enough of it to get to that 600 to 800 units or the micrograms that you need for your daily intake, it's going to be very hard to use it from fortified sources. So for most people, they're going to need a vitamin D supplement, a vitamin pill that they take on a daily basis from a good source to meet their daily needs. Some movements that you should avoid are things that include twisting motions. So things like twisting to tie your shoes, turning around in the car to do a shoulder check or to look in the back seat, or bending at the waist, all can put stress on that spinal cord and can lead to fractures if someone has very low bone density. We do not recommend sit-ups, bend over rows, some yoga positions, overhead reaching, and so on, as these pictures depict, because they put too much stress on the spinal cord. Another way you can tell how well your bone health is to look at how many number of teeth you still have in your mouth. And good oral hygiene practices and having all dental work done before you start any sort of osteotherapy, prevention, or treatment therapy can prevent a rare side effect that you may have heard of in the news called osteonecrosis of the jaw, or ONJ. If you've already been started on therapy for osteoporosis and something happens, you get a broken tooth or they need to do some work, if it's in the first few months after you've started therapy, you will likely have a very low risk and it likely will not happen. Where we see this increased risk is typically after 4 to 5 years of drug therapy from pretty much any of the classes of drugs that can treat osteoporosis. And dentists need to be aware that you're on that therapy, and they can provide antibiotic rinses or antibiotic oral therapies that can also prevent ONJ if you need to get any work done while on osteoporosis therapies. Lastly, they may decide with your physician that you need a drug holiday, and this so you may stop taking your therapy for a few weeks to a few months until everything has been healed, and then you can go back on your therapy if your doctor feels that it's appropriate for you. Everyone asked me about other supplements that can be used. Unfortunately, the studies tend to be contradictory or very small and hard to generalize to all people. Magnesium has not performed very well, but we do know that is a key component with calcium in the hydroxyapatite, which makes up that matrix or spongy part of the bone. Calcium tends to cause constipation for some people, and magnesium is a natural laxative, so it can be a reason to take a calcium magnesium combination supplement. If you take too much magnesium, you could get diarrhea, and then just back off on the amount of magnesium. Zinc and vitamin K2 have also had some small positive studies that in low doses for zinc and in a regular dose of the vitamin K2, they may be helpful to bones. But again, run it by your provider, because vitamin K can affect certain blood thinner therapies like warfarin. A lack of other vitamins can lead to compromised bone health, but if you have normal levels, it does not seem to add any benefit to help your bones. And soy, while it may have a small impact on your spine, doesn't seem to benefit your bones in other places from a meta-analysis in 2011. Strontium has been used in Europe on prescription for osteoporosis, but it's limited by findings that it can cause myocardial infarctions or heart attacks and some neurological side effects such as seizures and headaches. And so I typically do not recommend strontium. The strontium that they have tested in Europe is the strontium ranolate salt. Here in the US, you can get strontium citrate at health food stores or on Amazon, but strontium citrate has never been tested in the bone health realm, so we don't know if it would act the same way. And it can also negate the results you get from a DEXA scan because it overestimates your bone density having the strontium there. So I do not recommend it. And last but not least, fluoride, while is great topically for your teeth, oral supplementation leads to brittle bones and is not recommended. And my last slide here is typically supplements are not FDA approved. And so you need to be careful, use a company that you feel is using good manufacturing habits, or look for certified products. Example is USP verified type products, and report any side effects or drug interactions to the FDA because they are highly underreported. So now that I'm done my portion, I can't wait to hear from our next speaker, Dr. Heithaus, on how vertebral compression fractures are diagnosed and treated.
Thank you so much, Joy. That was very useful information. Let's see here. Try to share my screen now. Okay, excellent. So I'm an interventional radiologist. Admittedly, my mother still doesn't understand what I do, but an interventional radiologist, to sum it up in very brief terms, is a minimally invasive procedure physician. And so I'm here to talk to you about some of the minimally invasive procedures that we treat patients with spinal fractures, and some of the new technology that we've adopted here at Shands to really be on the cutting edge of what we can offer patients with compression fractures. So my talk is really going to be centered on patients who have existing compression fractures or develop fractures in the future, fractures that are older than, say, 6 months or longer, or chronic, and they're difficult to treat. We can talk more about that later. The spine is made up of vertebral bodies. I like to use the analogy, they're like cinder blocks with these discs or these cushions in between, and they're responsible for holding a lot of the weight of your body. There's a lot of stress on the spinal column, and when the bones get thin, you can get a compression fracture where the actual vertebral body will squeeze down or compress. The most common risk factor being osteoporosis, but other things like cancer invading the bone, infections, there are other things that can cause vertebral body compression fractures. As Joy mentioned, there are a number of risk factors. And as she described previously, the bone in the spine and elsewhere in the body is almost like a sponge. It's a small network of hard pieces that are all linked together. And as we get into osteoporosis, the bone thins out, it becomes soft, and it becomes more prone to fracture. And as we develop osteoporosis, we go from normal bone down to abnormal bone. And then we eventually in the spine can get compression fracture deformities. One of the biggest risk factors is just age and sex. So, as you've heard previously, up to half of women over the age of 50 will develop a osteoporotic fracture in their lifetime, and up to a quarter of men. And this is a serious problem here in the US in particular, that close to 750,000 people in the US will develop a compression fracture every year. And of those, 10% will need to be hospitalized to that, usually for a long period of time, almost 8 days. The other problem with these osteoporotic fractures is they increase your mortality, meaning risk of death. And so people who have these fractures are at a higher risk of dying at an earlier age if left untreated. So how do we diagnose a compression fracture? Oftentimes a patient has very minor trauma. So if you have osteoporosis and you bend down to pick up an item, or maybe you twist wrong, then you can have sudden pain in your back. It can be severe or it can be very mild. So what happens when you have pain? You go to your doctor. Oftentimes they start with x-rays, and that will allow us to see whether there's a fracture or not. Sometimes subtle fractures can be missed on x-ray. There's CT scan, or some people call CAT scan, that gives us great bony detail to the fracture. But the treatment or the imaging modality of choice is MRI. MRI is where we put you inside of a magnet and we image the bone. We're actually able to see the edema associated with the fracture. If someone has a pacemaker or other metal implant that precludes them from MRI, we can use other tools like a bone scan to look for edema in the fracture. And the problem with these fractures is it can be a downward spiral. We often prescribe non-surgical or conservative treatment options. Bed rest, sometimes we use physical therapy, a back brace, or even pain medications, Tylenol, Motrin, or even opiate pain medications. And the problem is if we don't fix these fractures, they can lead to a downward spiral of further pain, further what we call kyphosis, or that hunching over. You can't breathe as well. You may feel short of breath or tired, may not sleep well or eat well. That decreases your overall activity level, which then puts you at risk for worsening osteoporosis and additional fractures down the line. This is the back brace I mentioned. So if anyone on this webinar today has ever had a vertebral body compression fracture and ever been placed in this back brace for 6 or 8 weeks, they can tell you that it's quite uncomfortable and cumbersome. So one of the things that we can do is we can correct these fractures through a number of means, mostly through injecting bone cement. And this has been studied and shown to provide good pain relief, improve patients' functions, and restore their spine to normal alignment. This is just kind of an overview of the history of minimally invasive spine treatments. Back in the 1980s, we found that when we inject bone cement into the broken bone, that helps with pain. That evolved into a technique where we inflate a balloon in the bone to sort of create space and hopefully restore the height of the vertebral body, and then inject that with cement. And that provides great pain relief. There's various implants that have been developed over the years, but the most recent spinal implant that's been developed is something called the spine jack. And that's almost like a scissor jack for your car that will actually restore the vertebral body to its normal height. And that helps with pain. So this is an overview of the kyphoplasty. People hear kyphoplasty or vertebroplasty. It's a minimally invasive technique in which we insert a needle into the bone, subsequently a balloon into that area of fracture. We inflate the balloon, and then we fill that cavity with cement. Some patients get excellent pain relief, even instantaneously or within a couple of days. The newest technology that we offer here at UF Health is what we call the spine jack. And this actually helps us restore the bone to its near anatomic position, its original alignment, helping prevent future fractures. What we do is I drill into the back of the bone here and insert this small scissor jack, one on each side of the spine, and actually expand this up to restore the fractured bone to its original height. Here's a video depicting the spine jack procedure where you can see this scissor jack actually expanding the bone and restoring normal height and alignment in that bone. And at the end, you'll see some black bone cement that we inject. Pretty neat technology, all done minimally invasive on an outpatient basis. I want to show you 2 cases real quickly before we open up for questions. This was a 67-year-old lady who came to see me because she had twisted wrong and she developed a fracture. We did a bone density scan on her and it confirmed that she did have osteoporosis. She had pain for several months and was treating it at home with Motrin, but subsequently developed some bleeding in her intestines due to too much pain medication. You can see on the MRI here that the fracture level is not like the level above and below this MRI. And this MRI image depicts all the white edema within the bone from the fracture. So I bring her in for an outpatient procedure, give her some medication to help her relax, lay her on the table, and insert 2 small needles into the back of the bone. Once I insert these spine jacks, I actually slowly expand them up to bring the bone back to a normal position. And here at the end, you can see this patient got excellent height restoration in her bone. She had immediate postoperative relief, which we always hope for. She came to our procedure area in a walker, and she was able to walk out under her own power without it needing any assistance at all. Excellent result. Here's another patient who had an excellent result. She had back pain while she was gardening, also sort of that bending over position, and she developed a fracture. This is an X-ray that shows the fracture right there. She was a smoker, which Joy mentioned is one of the risk factors. We do encourage patients to cease using tobacco. She also was using steroids because she had COPD or lung disease. She was using oxycodone for pain relief, but was having a lot of side effects, including abdominal pain from the constipation. Here's her MRI where you can see the bony edema there, all that white in the fracture plane, and you can see the height loss in that vertebral body. So I offered her a procedure. She came in. We started the procedure by inserting 2 small needles into the spine. You can see the height measurements of these bones here, significant compression fracture deformity there. By slowly expanding the jacks, we can get to that vertebral body back to a normal position, functional. And this patient had great pain relief. Remember, she was 8 out of 10 in pain before the procedure, 4 out of 10 on postoperative day 1. And I saw her in the clinic 1 week later, and her pain was essentially gone. She was no longer taking her narcotic pain medication. I was able to get a bone scan on her, also showed she had osteoporosis. So we talked about osteoporosis management, and I got her referred appropriately to a primary care provider. So this procedure, whether it's kyphoplasty, vertebroplasty, spine jack, these minimally invasive spine procedures are made through 2 tiny incisions in the back, less than 1/4 inch in size, no stitches. This is an outpatient procedure. Patients come in and go home the same day, and they recover very quickly. And so these are some of the minimally invasive options we have. If you want to find us on YouTube, you can just search for UF Spine Jack. There's a video where I talk a little bit more about these procedures. For those of you who are watching this on your phone today, you're not going to be able to scan this QR code. But for those of you who are watching on your computer or maybe a tablet, if you take your phone and you open up your camera and you hold it up to this QR code, that will give you a direct link into our YouTube channel. And then similarly here, I have another QR code that has our phone number and our fax number. So if you are a UF patient, a UF Health patient, and you have been diagnosed with a compression fracture within the past 6 months, and you are having persistent pain, you can ask your primary care doctor or any other doctor that cares for your UF to put what we call a referral in. That's basically an electronic request for me or one of my partners to see you in clinic. If you're not a UF patient and you have been diagnosed with a compression fracture and you're having pain from that, and you'd like for us to evaluate you, you can have your outside primary care provider or any other doctor outside the UF Health system fax us a referral at that number there. Look forward to treating anyone we can with some of these minimally invasive therapies. If you've had a fracture, but you've recovered from it and you develop a future fracture, please don't hesitate to call us. We're happy to get you in as quickly as possible and get you treated, because if we can get you pain-free or get your pain much better, it's going to greatly improve your quality of life. It's going to allow you to do those weight-bearing exercises and other things to help you increase your bone mineral density and reduce your risk from osteoporotic fractures. So thank you so much for your time.
All right. Thank you so much for doing that. That was great. We've had a lot of questions come in. Let me get to the first one. This is probably more for Joy. If you can't take biophosphates, what are your options? And can you discuss any side effects of that? I know you covered that a little bit, but.
I did. I had the whole slide. So there's probably 7 or 8 different classes of medications that if you can't take bisphosphonates, you can try one of the other ones. And depending on your situation, there may be one of those classes that are better than another one. Most of them are very low in side effects. Because they're building bone or attaching to bone, they can come with a very small risk of some bone pain. Some of them are more upsetting to the stomach than others, but really they don't have a whole lot of side effects. It's more the rare things that we hear about, those 1 in 5,000 to 1 in 10,000 risks of the osteonecrosis of the jaw, the abnormal femur fractures, things like that we get scared about, that even esophageal cancers that are very, very rare, that you know, we can treat thousands of patients and never see them.
Okay, great. Let's see. Is there a time, this would be for Dr. Heithaus, is there a time limit after the fracture that you can still receive treatment, or a time period that's too late to receive treatment?
That's an excellent question. And we struggle with that question in clinic on a daily basis. Is, you know, back pain is a complex problem, and it can be from a number of factors. Patients who have fractures can have back pain from unrelated conditions like degenerative disc disease or other things. And so when we talk about someone with back pain, we really have to speak to the patient, review the imaging, perform a physical exam, and figure out, is that pain related to a fracture or something else? Generally speaking, chronic fractures more than 6 months are very difficult to treat. And even if we treat them, patients don't get a lot of pain relief. There are patients who have chronic fractures that still have edema in those fractures. And so we offer an MRI evaluation. If we still see that there is swelling or edema in the bone, then we can talk more about that. But generally speaking, these minimally invasive procedures, it's best if they are performed shortly after the fracture, within a few weeks to a few months. So if you go to the ER, you go to your urgent care, you go to your primary care doctor with back pain, they diagnose you with a new compression fracture, it is important to be seen in a timely manner to have that fracture fixed.
Okay, and here's a question. Is systemic lupus a risk factor for osteoporosis?
Again, it would be considered an autoimmune issue. So yes, depending on how it's treated and how much inflammation has been in the system, it could be a minor risk for osteoporosis.
Okay. And then Joy, another question that's I think for you, is it better to take vitamin D or vitamin D3?
Most of our sources are going to either be vitamin D2 or vitamin D3. Either is fine, but D3 seems to be a little bit better absorbed. So if you have a choice, I would typically pick the vitamin D3 over the vitamin D2. But you can get both of them over the counter pretty easily.
And how do you know what's a good brand of a vitamin that you're purchasing? Is there any thing we can look for with that?
Again, following good manufacturing procedures. If you know the company's branding, I'm partial to USP verified, which is typically your nature made brand, because they are tested by USP to make sure they have what they say on the bottle is in the bottle. But there are some other brands that are now becoming USP verified, so you just have to look for that seal on them or really investigate your company. Something else that I often mention is if you're starting any sort of herbal or supplement product, take a diary of your symptoms for a week or two before you're going to start it. Use the product for 3 months or so to give it a good try. If you're not seeing a difference when you take a symptom diary again at that point in 3 months, then maybe change brands or see if you need a different supplement.
Okay, great. Dr. Heithaus, question for you. Can you do the spine jack on the cervical spine?
No, unfortunately not. We're limited to the thoracic spine and the lumbar spine. So the mid back and the lower back.
Okay. And does Medicare cover those treatments? For the
Medicare does cover those treatments. And when we evaluate patients and we deem them appropriate for a procedure, we do undergo what's called pre-authorization. So before you come in and actually have a procedure done, we make sure that what we want to do is covered by your insurance.
Okay. And let's see. And then, let's see, what type of doctor is going to diagnose this compression fracture that a person might experience?
So most commonly, it's going to be a doctor who you see maybe in the emergency room. So let's say you have a fall and you're taken by ambulance or by a relative or a friend to the emergency room. That would be someone who would diagnose you. If you go to, say, an urgent care clinic or your primary care doctor, that would be someone as well. If you have, let's say you're going for a well woman visit to your gynecologist, they know that you have osteoporosis and you happen to mention that you have this problem of a back pain that's new after trauma, that may be another physician who would diagnose you. But most commonly it's seen in the primary care setting as well as in the emergent and urgent setting.
Okay, perfect. Thank you. Joy, could you kind of review quickly, like what and how much calcium should be in a supplement that we should be taking?
So again, it's the combination of how much you eat of calcium with your supplement should be in that 1,000 to 1,200 milligrams a day of elemental calcium. So as we said, about 300 milligrams per serving of milk products. If you drink milk, you eat hard cheeses like 1.5 ounces, or you're eating 6 ounces of yogurt, that would be equivalent to about 300 milligrams of calcium. If you're using some of the green leafies, you may only be getting 100 to 200 milligrams. So you have to add up all those sources and see if you can hit that 1,000 to 1,200 with your diet. If you can't, if you're consistently only getting about 500 in your diet, then I would add a calcium 500 supplement once a day to it. If you're not getting any calcium at all a day, then you could do a calcium 500 milligrams twice a day supplement. And again, you never want to take more than about 500 milligrams of calcium at a time because your body can only absorb so much per setting. So again, if you're going to get milk on your cereal in the morning, then you may want to take your calcium supplement at lunch or dinner if you don't eat calcium at those times.
Okay, good information. Yeah, that's always hard to juggle all that. So I appreciate that. Dr. Heithaus, how long does the spine jack procedure last, or how long has it been tested for? Like what's the lifespan of that?
So this technology's been available in Europe since 2008. So it's been around. There have been big clinical trials evaluating this in the European literature. And most recently, it's been approved by the FDA for use in the United States. So we've had this technology for the past year or two here in the US. And as soon as it was available, we tried to get it here at UF so that we can be on the cutting edge. But there is great data to support this technique, whether it's spine jack or other procedures like vertebroplasty, kyphoplasty, where we inject the bone cement to fix the fracture in place to try to relieve pain.
Okay. Someone wrote in that they have a T12 compression fracture, plus all of the lumbar vertebrae have osteoporosis. Is that something that can be treated?
Potentially, depending on the age of the fracture, that would be something that we could evaluate in clinic.
Okay. Let's see. And Joy, I think it's a question for you maybe, but should people on aromatase inhibitors be treated prophylactically?
Again, it would be something to talk to your physician about. Some of the cancers do take calcium out of the bone, and some of the therapies we use to treat cancer. So it would be good to see if you have other risk factors that are contributing, and then whether they want to look at it as a prevention or as a treatment for osteoporosis, depending on what you have. So it's a good conversation to have with the physician.
Okay, great. Dr. Heithaus, when the person is receiving a spine jack procedure, are they sedated, or what kind of, how is that numbed up so that?
Absolutely. Typically, we do it under what we call moderate sedation. Some people use the term twilight anesthesia. We give you some numbing medicine in your back along the small incisions, and then some IV pain medication and some anxiety medication. Both of those work synergistically to help you relax. Some people fall asleep during the procedure. Some people remember some of the procedure, but some people don't. We customize the level of sedation based on patient risk factors and needs. So this is a minimally invasive procedure. It usually takes an hour or less to do. And so we find that patients come in, we give them a little bit of sedation to make them comfortable. We do the procedure, and oftentimes patients feel better after the procedure, and it's a quick in and out thing.
That's great. That's great. Joy, you recommended estrogen to keep your bones dense after menopause. Is there a risk like to your cardiac health or otherwise to continue wearing estrogen or only a transdermal patch even after a hysterectomy?
Again, it's a conversation you have to have with your doctor, because we are finding, back in the 90s when I started practicing, we gave estrogen and progesterone to everybody, and we realized that that's a problem. So not everyone is a great candidate for that therapy. If you have a history of cardiovascular disease, any family history of breast cancer, probably estrogens and progesterones is not your way to go. If you are a good candidate for menopausal therapy, you're having some hot flashes, you're having other symptoms of menopause, then we may use the estrogen and progesterone for a couple of years, but you're probably not going to be on it long term. But again, it's got to be a conversation with you and your doctor who knows your personal history and knows kind of what your risks are, whether that family of drugs is good for you or whether it's better to stick with other types of medications.
Okay, thank you. Can a radiologist tell the difference between osteoporosis and erosive osteoarthritis?
That's an excellent question. And I would refer that to one of my musculoskeletal colleagues.
Okay.
I'm assuming that's someone who's talking about it in maybe their hand or a joint space. We're not able to declare someone has osteoporosis based on an X-ray, a CAT scan, or other means. We can just see that the bone is thin. We call that osteopenia. Only a bone scan can we diagnose someone with osteoporosis.
Okay, so kind of a follow-up question. Actually, another person submitted this. I've had a spinal fusion and 2 hip replacements. Is scanning my wrist enough, or is there something else they can scan to test for osteoporosis?
Unfortunately, once all of that hardware is in place, we have to stick with bones that don't have screws or plates in them. The wrist has been a well-validated method to determine if someone has thin bones and to monitor the progress of therapy. So I would stick to the wrist DEXA scan. There's a set of standards that we can follow. And so we know whether we're telling someone if they actually have thin bones or not. It sounds like with all of those problems, this person may have osteoporosis indeed.
Okay. So I asked a question earlier about how long does the spine jack last? And I guess I didn't clarify, but does it need to be redone after a certain amount of time?
No, usually spine jack or kyphoplasty or vertebroplasty, and those procedures are done in a single session and you only need it done once. It's very uncommon for patients to come back and need a second procedure at the same spinal level. It is common, however, for patients to develop new fractures down the road, whether it be 6 months or 6 years later or anywhere in between. Just because, say, I fix a spot in the lumbar spine doesn't mean because you have osteoporosis, you have that risk factor for fractures, that you don't come back 6 months, a year, 2 years later with a new fracture at a different spinal level. Remember that I showed you a picture of the spine where there were a bunch of blocks stacked on top of each other. So once you fracture one level and the bones are thin, you're at risk for fracture at all the other levels. So it's not uncommon once I get to know a patient and I perform one procedure on them, that I do see them again in their lifetime for additional procedures at other spinal levels due to subsequent fractures.
Okay, great answer to that. Someone asked, if I have a compression fracture and a bone fragment, should that bone fragment be removed? And can you do that at the same time?
That's a very individual specific question. I probably want to see you in clinic and actually see the details of your medical history and your imaging to determine if you're a candidate for any procedure.
Okay. So someone asked a question. It would seem that the heel is the densest bone in the body. So are heel scans available at health fairs, et cetera, useful?
That's an excellent question. I'm not entirely familiar with the standardization of heel scans, but I know in my practice, we use DEXA scans and evaluate the lumbar spine, the hip, and the wrist. And those have all been validated or verified with clinical trials and clinical data to show that that's actually useful. I think if you're going to be out and have a heel scan that shows that there is some risk, that, you know, it may be useful to obtain a DEXA scan after that. But I would say if you're a patient who falls in that category based on age or other risk factors, that you should consider having your primary care doctor obtaining a standard DEXA scan.
Yeah, the heel scans that I've seen in pharmacy typically are ultrasound machines, and they state right in the packaging that they are not diagnostic. So that it's just giving us an idea of whether you might be at risk or not, so that you can, as Dr. Heithaus says, get further testing from your PCP.
Yeah. We actually have one at UF Health that we take out to events and I help with that sometimes. And, you know, our usual answer is this isn't diagnosis of anything. It's a snapshot. It's something to start a conversation. Again, it's looking at one part of your body, not diagnosing anything. So that's kind of the general information. A question about water walking with ankle weights. You talked a lot about exercise and different exercises that were good, but how would walking with ankle weights in the water how that help?
Again, it's great for your cardiovascular health, so your heart would be great. Even adding ankle weights, the water is still buoyant, so you're probably not going to get the full benefit on your bones, but it's not a bad exercise. I would just add stretching or weightlifting along with water walking.
Okay. And another question, a lot of questions about calcium. Is there a difference, different types of calcium, or are we looking for calcium carbonate?
Calcium carbonate is the most common form, and it's probably the cheapest form. The problem is you do need acid to be able to absorb the calcium carbonate. So if someone is on medication to suppress the acid in their stomach, things like H2 blockers or proton pump inhibitors, I would move them over to a calcium citrate, or if they're older, I like calcium citrate better just because a lot of times people over the age of 65 or 70 are not producing as much acid to be able to absorb the calcium carbonate well. Really, you don't need expensive calcium supplements. And I always say the best supplement is the one that you're actually going to take. I don't want it just to sit on the counter or in your cupboard. And so if you preferred using the Viactive calcium chews, because it tastes like a candy or some other gummy formulation, I'm okay with that. I just want to get the calcium in there as long as you need calcium. And again, making sure you're not getting too much by looking at your diet with the supplementation.
Okay, thank you. Dr. Heithaus, would the spine jack or a bone cement procedure be appropriate for someone with disc problems or chronic pain in their back?
No, generally not, unless we determine your pain is associated with the fracture and your pain is not related to the degenerative disc disease. Again, it's a complex picture, and that's why we like to see patients in clinic and talk to them and really try to figure out where exactly their back pain is coming from. Now, let's say as we age and we have degenerative disc disease just as a baseline, and then you develop a fracture on top of that, having the degenerative disc disease doesn't preclude you from having a procedure. It's just important for us to figure out, is your pain related to a compression fracture or is it related to something else?
Okay. And this is something that's kind of related, but I'm going to go ahead and ask it because I think probably both of you have some expertise in this area. But can a woman in her late 70s have back surgery for scoliosis?
Joy, I'm going to let you start if you have an opinion on that.
I don't have an opinion on that, although
okay.
The funny part is that I've had scoliosis surgery, but I started much younger. So I'm not sure. And again, that would be, I don't know the other health risks the patient has that's over 70 with scoliosis. So, you know, what is their heart health like and things like that to be recommending any sort of surgery. Dr. Heithaus?
Yeah, that's scoliosis surgery is sort of out of my expertise. And so I would ask that you just defer to your neurosurgeon or orthopedic spine surgeon, whichever physician you're speaking to about your scoliosis surgery. Those are the people who know you the best. Those are the physicians who are going to be able to evaluate you, talk to you about the risks and benefits of their procedure and whether you're an appropriate candidate for that.
Okay. Joy, you kind of talked a little bit about how great stretching and things like that were, and getting your muscles and bones stronger. But, you know, also then you said, these are some of the things you should avoid. And they kind of seemed like the same kind of things. You're like, on one hand, this is good for you to get stronger. On the other hand, don't do this, this, and that. Could you talk about that a little bit more?
Again, you don't want to be putting any weight above the head, but using your arms and doing curls or doing arm lifts up to your shoulder height are typically seen as safe. If you're doing weightlifting, working with a trainer who's familiar with osteoporosis is definitely of benefit. I don't know of anyone here in Gainesville, unfortunately, but I did work with someone up in Niagara Falls area who was had special certifications in osteoporosis, so she could give specific exercises to someone with osteoporosis and would tailor it if they were osteopenic or osteoporosis. Definitely, you can do pretty much any of the leg kind of exercises as long as you're not putting the weight on the shoulders, like the squat machines where they're putting the weight on your shoulders and then you kind of come up into the machine. Those would be risky, but any sort of leg extensions to get your legs stronger, those would all be safe. A lot of times, even just starting with very minimal weights, like a can of soup, is all you really need into working your arms and your legs and using your own body weight. But just avoid those twisting motions. And again, a lot of the things I was saying are for someone who has a diagnosis of osteoporosis or thinks they may be at high risk for osteoporosis from that list. If you don't have osteoporosis, all exercises based on you and your physician's conversation are probably safe.
Yeah, and one of the things I've learned in doing these talks before is that your physician can send you to physical therapy to help with osteoporosis, to show you the right way to do stretching and strengthening exercises to get your core and your limbs even stronger. So you can talk to your physician about a referral to PT to help.
Absolutely. Yeah, we do that when I fix fractures in patients. One of the things I typically do is offer physical therapy referrals to patients so that they can get back into the appropriate exercises and the appropriate body mechanics to strengthen their core and work on weight-bearing exercises to help build bone mass. Again, patients who have osteoporosis or severe risk factors should be cautious, but those who have normal bone mineral density should be doing weight-bearing exercises on a regular basis to help build and maintain bone density.
Okay. So someone says they were diagnosed with osteoporosis in the hip and spine recently, and they're being followed by an endocrinologist who's beginning treatment on them. But they said also they've had some pain in their back that will knock them out for a couple of days, and then it tends to get a little bit better. They've had it x-rayed before and they didn't see, anything on those x-rays, but they were kind of wondering, should they do more? Should they get an MRI to see if there's compression fractures, or should they just wait until their next appointment?
That's something I would talk to your individual doctor about. If they're concerned that you have a compression fracture, they can certainly order an MRI or some other imaging. X-rays are excellent screening tools. And so if someone's having back pain and you get an X-ray done and there's not a compression fracture there on the X-ray, that's a pretty good screening tool that will catch a majority of patients. Some patients with extremely brittle bones can have mild compression fractures with minimal height loss. We don't really see that on the X-ray. That would be something to talk to your doctor about as to how suspicious they are that you have an underlying compression fracture or that you're having back pain, maybe related to degenerative disc disease or some other problem.
Okay, great. Let's see. Someone says, is there a way to get into a back pain clinic if your doctor doesn't take your pain seriously? No x-rays or tests, only using anti-inflammatories that don't help. Any thoughts on that? I know we have the Comprehensive Spine Center and you don't need a referral to get in there. Although if you have imaging, they'll want that as well, but you can call them. But any other thoughts about that? Like you've talked to your doctor about your back pain and they kind of don't want to do anything about that?
Yeah, absolutely. You can get evaluated at our comprehensive center here at UF Health. We also have pain management clinics and on an outpatient basis and physicians, anesthesiologists who specialize in pain management. We have neurosurgeons, orthopedic spine surgeons. We have a whole host of physicians who can try to help diagnose and treat you. Back pain is a very challenging thing to treat. And oftentimes we do MRIs, CAT scans, all sorts of imaging, and we just can't see anything wrong. But that doesn't mean that a patient's not experiencing pain. I certainly do believe that when someone tells me they have pain, I do believe that. And sometimes we do all of this big medical workup and we just don't see what's wrong. Doesn't mean it's not necessarily there.
Yeah.
So I would recommend going to our comprehensive spine center or seeking out our anesthesia pain management colleagues by searching for them at ufhealth.org.
Yeah, in case anybody's out there and wants to know, I just happen to know their phone number because I pass it out a lot, but it's 352-265-SPNE. That's SPNE, kind of like spine. So I don't know all the numbers for it, but I remember that little handy phrase. Joy, can you talk about calcium from seaweed found in like any supplements that have algae in them?
I'm not specifically familiar with algae. I know a few years ago, there was some products that were calcium from the waters of Japan. And so everybody was trying to get coral calcium, if anyone remembers that, back in the early 2000s. And then it came out that it was really just a glorified calcium carbonate. So I'm not really particular on the type of calcium. I'm really looking at the elemental calcium and getting it in you to the level that you need.
Okay. Let's see. Here's a question. I hope I'm reading it right. Based on your T-score and osteoporosis, do some patients start bone building medication rather than the first line of bisphosphonates? Like, do they kind of, if they already know what their T-score is and they know they have osteoporosis, can they jump to the next level of things?
Most of the time not, because the insurance companies are going to limit the access to those really expensive drugs by having you fail the cheaper drugs first. But again, if your doctor feels that you're not a good candidate for a bisphosphonate or some of the other oral medications and they want you on the bone building therapies, they may be able to write a letter of appeal to the insurance company and see if you can start with something different.
Okay. Can minimally, this is for Dr. Heithaus, if you have osteopenia and scoliosis, can a minimally invasive treatment like spine jack or the bone cement, can those help with that?
Generally speaking, those procedures are reserved for patients who actually have acute compression fractures, meaning active fractures with edema in them. Unfortunately, as we get older and kyphosis worsens, that hunched over position, although the mechanics of this procedure would potentially align your spine better and increase that height, it's not approved by the FDA and by insurance companies for that off-label use. So no, unfortunately not. And if you don't have an active or an acute, what we call an acute fracture, you can't use those procedures for that condition.
Okay. Joy, is there a way to, and maybe this is a little bit too in-depth, but is there a way to get coverage for some of the injections if maybe you can't tolerate something that's oral, like the person must have Medicare?
Typically, they're going to be prior auths through the insurance company. The physician would have to fill out the paperwork and state why you didn't do well on the bisphosphonates or why you won't do well on other oral therapies if you haven't tried them. And make the case for you to get the injectables. And so that's typically called the prior authorization process. If your insurance company denies the prior auth, then you can go to this appeal letter process with most insurance companies. And if that's still denied, then often the companies have some patient assistance programs that the physician can apply and see if the company will provide the medication to you if your insurance company won't cover it.
Okay. So with these appeals, is that something that the individual does themselves? Their physician helps them with, the pharmacy helps them with?
Typically it's the physician's office.
Okay.
And again, different physicians are more comfortable or less comfortable with it. I know when I was up in the GI clinics, 8 to 10 years ago, we did a lot of appeal letters to get patients on some very expensive drugs for some GI issues. So it's probably more in the wheelhouse of a specialist than the primary care physician. They may not have time to do all of the paperwork needed. So at that point, you may want to go to an endocrinologist or other specialists to be treated for your osteoporosis, because they probably have more experience doing the letters of appeal and the prior authorization processes. But no, it's typically taken care of by the physician and not the patient themselves.
Okay. Let's see, could you talk a little bit more about the GI side effects of some of the bisphosphonates?
So bisphosphonates typically are very irritating to the esophagus. And so that's why we tell patients to take them with a large glass of water to try and help flush it through. And so if they're not taking it with enough water and it gets stuck there, it can actually irritate the esophagus to the point of causing erosions or little divots in the esophagus. The risk of esophageal cancer, again, is very, very rare. It's about 1 in 1,000 patients treated with a bisphosphonate would be at a higher risk of esophageal cancer, as opposed to patients who are not taking those type of medications. So it's very, very rare that you're going to get problems with that, but it can be irritating, especially if they're not taking it with enough water, and they do need to stay upright after they take it. The reason they don't want to lie down is, again, that tablet can come back up from the stomach into the esophagus. So you want to stay vertical so that that tablet is going to go down to the stomach and stay down, so it's not going to cause the irritation to the esophagus.
Okay. Let's see. One of the questions is kind of an overall question. So once you've got osteoporosis, do calcium, vitamin D, and weight-bearing exercise just build bones, or do they help stop the progression?
Typically, they're more thought to stop the progression, although there have been a few studies that show slight bone building with, again, the more aggressive exercise. But again, I would say, as you mentioned earlier, physical therapy is probably your better bet there to see what aggressive type of exercises the patient would qualify for. So exercise can build a little bit of a bone, especially if you're doing some higher impact stuff and you're capable of that. But again, if you're very frail, I would definitely not have you do those sorts of things. Calcium and vitamin D, really, if you're starting it at the point of osteoporosis, it's probably, as I mentioned earlier, a little bit too late, but you will see slight benefits, but it's probably more preventing bone loss as opposed to building anything.
Okay. Any other thoughts or anything you guys want to say that we haven't covered or addressed already? No? Okay.
No, thank you so much for this opportunity.
Yeah, I think everybody for joining us. We had a great audience today and a lot of great content and great questions. So thank everyone for joining us. Like I mentioned earlier, I'll send a link out with the recording and some of the information that was included in there, and hopefully get you some good resources that I can include in there as well. So thank you guys both for taking time out of your very busy days. And thank you everyone in the audience for joining us today. Thank you so much.